Managed health care came about as a result of dramatically increasing health care costs. Technology was improving, but technology is expensive. An aging population was creating greater challenges for a system which was already placing heavy burdens on insurance companies, on employers faced with increasing premiums, and on government attempting to support people unprotected with coverage. We heard stories of physicians and other healthcare providers abusing the system with too many tests, procedures, and surgeries. Managed healthcare has slowed the increase in costs, but research regarding managed care suggests that patient dissatisfaction is growing. Judith Rothschild has been at the forefront of an effort to determine whether the quality of care really has been affected by healthcare policies favoring managed care. Her recent survey, published in this month's issue of the American Journal of Nursing, revealed that 2 out of every 5 nurses in the nation would not want a family member to receive care at a facility where they worked. And an even higher percentage indicated that the quality of care in the Northwest was diminished by cost-saving measures. Dr. Rothschild teaches healthcare policy and health economics at the Boston School of Nursing, and her research and writings have been widely quoted in the national media. She will share with us her conclusions about the data she collected with a focus on responses developed from nurses in the Northwest. Judy Uherbelau is an Ashland attorney with the law firm of Thomas Hauser. Earlier in her career, she worked as a registered nurse, first in an emergency room practice, and then she joined the Peace Corps to serve in the Mariana Islands in the Pacific. After coming back to the States, she went to the UCLA Law School, then moved to Oregon and began practicing law in Ashland. Judy's been very active in health care and issues relating to the elderly. She's also been active in the state bar, recently serving as chair of the Oregon State Bar Ethics Committee. Judy was elected to the Oregon House of Representatives in 1994 and was re-elected in 1996. Most recently, Judy has sponsored House Bill 2740, the Patient Protection Act, and today she'll talk to us about the need for patient protection legislation in Oregon. I believe that Dr. Rothschild will speak first.
Thank you. Good afternoon. I'm delighted to be here. I arrived at about 4 a.m. Boston time, so if I'm a little slow on the uptake with some of the questions, please excuse me. We finished at Boston College School of Nursing at the Center of Nursing Research, the largest survey ever conducted of registered nurses in the United States. Why is it important that a group of businessmen and women listen to the voices of nurses across this country? Well, for 2 big reasons, I think. First, we are the largest group of healthcare professionals in the United States healthcare system. And secondly, consumers trust us more than any other healthcare provider. What nurses told us in our national survey was surprising in some respects and not surprising in others. And I want to begin by talking about the things that are common across the United States before we get into some of the differences. First, we had almost 7,500 registered nurses answer the questionnaire, nurses from every state and territory. In Oregon, there were about 90 nurses, and in Washington State, about 1,000. So there was a sizable response from this region. What we found was that nurses across the country, in overwhelming numbers, about 3/4 or 2/3 of the nurses, said that there were fewer nurses taking care of more patients, and they were being cross-trained to perform more duties than ever before. We also found that about 2 out of 5 nurses, 33 to 40%, reported that the institution where they work is substituting cheaper workers for registered nurses or part-time and temporary workers for RNs. Now, when we examined this finding and to see if there were any regional differences in how nurses are being used across the United States, we did find that the Pacific Coast is notably different than the rest of the United States. especially when it comes to what we refer to as, I have a PhD in sociology and labor economics, and we call the substitution of cheaper workers for more skilled workers de-skilling. And de-skilling is occurring in this area of the country to a far greater extent than any place else in the United States. Now, why should a group of businessmen and women care about who takes care of them at the bedside? I'm sure you're familiar with lots of anecdotal stories. They've been on the press and on the news. When our report was first published in the November issue of the American Journal of Nursing, it was covered in Time magazine with an article entitled "The New Hands-Off Nursing." The story was picked up by Good Morning America, and I was asked to appear on that broadcast with a family who had lost their mother because an unlicensed assistive personnel, a nurse's aide, a tech, who was responsible for their mother, didn't recognize that she was slipping into septic shock, and she died. On this broadcast on Good Morning America, the family, the husband and the attorney, were quite clear and quite articulate that had there been a registered nurse at the bedside, their wife, their mother would be alive today. And Joan London turned to me in Boston and asked me if this was an isolated incident. And I had to reply, no, it is not an isolated incident. That I was familiar with another case that ABC World News Tonight was trying to broadcast of a similar situation, an 18-year-old college student in Boston, admitted to a Boston area hospital with an aneurysm. The family, just like this family, the Strunk family, never left this young woman's side. And they believed that the person coming in to take care of their daughter was a registered nurse because she looked like a registered nurse, because she was taking vital signs like a registered nurse, but she did not have the clinical experience, the knowledge, the skills, or the know-how to recognize that this young woman was literally bleeding to death right before their eyes. And she died too. And that family realized a record settlement too. But when they went to ABC News to come forward and tell their story, the hospital threatened to renege on the legal settlement. So their story, like countless others, remains untold. What we found in the AJN survey was a disturbing trend in terms of what's happening to patients and the quality of care in this country. A disturbing trend that I think warrants immediate attention by our legislators, our public officials, and yes, especially the business community and all of you sitting in this room, because you are the purchasers of health care. And if anybody can turn around this situation, it is you. We found record numbers of nurses, a majority of nurses, reporting an increase in readmission rates, especially for the mentally ill and especially for the aged. Those are two populations whose voices have not been heard. We now have national legislation that mandates 2 days postpartum care for newborns and their mothers to put an end through drive-through deliveries. Legislation that was spearheaded by, yes, anecdotal reports, not hard empirical evidence, because people knew at face value that that practice was wrong. And it's also wrong to discharge the mentally ill, people who are suicidal, the elderly, who may not have supports at home prematurely from hospitals. Well, why are these practices happening? Of course, we have to contain costs. Nobody would disagree with that. The United States spends more in its healthcare system than any other industrialized country in this world. Our problem is not that we don't have enough money. I do a lot of public speaking in Canada, and that's their problem. They don't have enough money in their system, but that is not our problem. We have plenty of money, but where is that money going? In terms of nursing, we have, without a doubt, the hardest working, most efficient nursing labor force in the entire industrialized world. While I grant you, as businessmen and women, you know how to make your operations run more efficiently, that if labor's a big component, you've got to try to make that part of your budget as streamlined and as productive as possible. But I'm here to tell you that we have made nursing very streamlined and productive as possible. And then if we continue it towards this trend of de-skilling nurses, of forcing them to take care of more patients, of working them to the point where they literally now we're seeing a marked increase in back injuries and work-related injuries among nurses, healthcare will suffer. Now, the waste in our system, everybody agrees where it is. That is not a big secret. That is not a political debate. The waste is in administrative overhead. Everybody agrees that's where the waste is. And we also have, as Ralph Nader has said on several occasions where I have spoken with him, both in Boston and in San Francisco, to consumers such as yourself, a level of greed in our healthcare industry that is frankly unprecedented. Nader says he has never seen the level of profiteering and suffering on the part of consumers that he is witnessing at the hands of the American healthcare system. Now, how can all of you in this room change that as purchasers of health insurance? You should demand that insurers provide you with data not just on how they're going to lower your premiums, but also on their outcomes. And I don't mean crude outcomes either, morbidity or mortality. Patient satisfaction, readmission rates, nurse-sensitive outcomes, complications in hospitals, the numbers of nurses that are available to take care of patients. What kinds of home care services will be provided to patients if they're discharged early? Those are all questions you should demand be answered before you decide what health insurance policy to provide to your employees. And you do have a great stake in this, because an employee that is readmitted time and time and time again with more and more complications is going to hurt your bottom line eventually. So I hope you join with the Oregon Nurses Association. They are leaders in this country in trying to fix what is broken with our healthcare system, and with your state legislators, to give consumers a voice and to do it in a way that brings some equity and balance to our system so that profits don't supersede the needs of patients. Thank you.
That's a hard act to follow, somebody who speaks for 20 minutes without any notes. I like to pride myself that I can usually do that, but my excuse this time is that the workload at the legislature for the last week and a half has been very heavy, and I was going to work on this yesterday and found out that I did not get out of Judiciary Committee hearings until 8 o'clock last night. So I do have notes here, and I will rely on them to a certain extent. I'd like to say good afternoon and how honored I am to be here with you. Although I have never attended your forums before, I'm certainly aware of your work and have read your position papers. I must say, however, that I did not know quite how prestigious the City Club was until I was having a casual conversation with the political reporter from my newspaper, which is the Medford Mail Tribune. And I happened to mention to Peter that I was going to be speaking at the City Club, and immediately his body language changed completely, and he kind of raised his eyebrows and said, "You're going to be speaking at the City Club." I also should say that in a way I'm coming back home, at least in part. When I was running in this last election, the description of me was continually as one being a Portland liberal. Well, I don't know if you're liberal, but at least you're Portland, and so here I am. I'm home. The issue that we're discussing today is an extremely important one. Before we get to the topic of patient protection in the age of the HMO, though, I think we have to acknowledge what kind of health care delivery we have. We are the one of two, and I'm not sure about South Africa anymore since it changed governments, but we are one of only 2 governments or societies in the Western world, in the industrial world, that appears to view health care as a privilege and not a right. The rest of the countries have universal health care. That way of looking at health care as a privilege has certainly affected how we deliver health care over the years. In the recent past, we had a system of fee-for-service. If you paid the fee, you got the service. I can remember the years that I worked in emergency rooms in the 60s, the first question we asked people as they came through the door, do you have a health insurance card or a checkbook that has a balance in it? And that's the way service was given to people. Concern, as was mentioned by the first speaker, about the rapidly escalating cost of health care, which was escalating at a much higher rate than the inflation rate, led to a change in the way we deliver care, at least a trend toward a change. Although we still do have fee-for-service, which admittedly encourages too much and unnecessary treatment, there is now a rapid shifting to so-called managed care. I want to pause here for a minute and say why I called it so-called managed care. I strongly believe, as do others, that the system we have is not managed care, but is a system of managed cost. If it were managed care, we would be focusing on the consumer of care. What we focus on is the economics of the care. The perception, if not the reality, is that managed care, as it exists today, does not have the best interest of the consumer in mind. A part of that concern is the fear that the industry is mostly driven by the profit motive. This fear is not dispelled by the reports of huge profit margins and the high levels of compensation for managed care CEOs. The genesis for the proliferation of legislation, both on the federal level and the state level, is, I think, because the consumer patient feels like they are merely incidental to the managed care process. Most of the legislation that is being presented appears to address 3 issues. One is quality, the other is access, and the third is choice. The problem is that the majority of the legislation has taken a piecemeal approach. I'm sure most of you have heard about the bills that regulate the amount of time that during childbirth you should be able to stay in the hospital. Now there's a bill before Congress, if it hasn't already passed, concerning mastectomies. The natural outcome of those type of bills is the result is thousands of bills. We will end up with a disease condition of the day bill. It is at least those of us who were working on the Patient Protection Act, and I give a tip of the hat to the Oregon Nurses Association because they have been very involved in this process over the last year, working with Representative Chuck Carpenter and myself on this bill. What we felt was needed was a more comprehensive approach, and that is what our bill attempts to do. For example, in the Patient Protection Act, we have co-sponsored and filed in the legislature. We don't say that childbirth gives you 2 days in the hospital or mastectomies gives you 3 days. What we say is those decisions, those clinical decisions, are to be made by the provider, the physician, whoever the provider is, in consultation with the patient under accepted healthcare practices indicated by criteria the Department of Consumer and Business Affairs shall adopt by rule. That last part, the accepted healthcare practices, I think gives some safeguard. The thought was, and I think there was certainly support for the thought, was that fee-for-service ran away with us. And there were no criteria, there were no guidelines, there were no parameters, so treatment just proliferated, and then we ended up with these rapidly escalating costs. But we put a parameter around here that these decisions are under accepted healthcare practices. A very important part of the bill is that in making such decisions, the provider will not be subject to penalties by the insurance plan, such as being removed by the provider panel. That being removed from the provider panel hangs like a threat over every physician's head about what they can and cannot do under these managed care programs. Along those same lines are what is known as the gag rule. This rule, which many HMOs have in their contracts, says that the doctor cannot discuss with their patient options for care that are not included in the plan. That is a very strong interference with the doctor-patient relationship. And it goes on, many of the plans go on to say that if you do, you can be subject to penalties. Most insurers will say that they don't have the gag rule, but I would suggest you read the fine print, because many of them do. To make choices in this atmosphere, one must be informed as to what those choices entail. That brings up the issue of disclosure. You know, it amazes me with the background in economics that managed care shies away from disclosure. We hear over and over again that if only our healthcare system used market principles, we would be much better off. Well, one learns in Econ 101 that one of the first tenets of the market system is perfect information. We realize there's no such thing as perfect information, but certainly the more information that is available, the more informed a person's decision will be. In the managed care situation, we are faced with making an informed choice about such issues as which plan most appropriately meets one's needs, making decisions comparing cost and coverage between plans, making decisions about complaint based on complaint resolution mechanisms, and so forth. Our Patient Protection Act focuses very strongly on requiring the gathering and disclosing of relevant information. For example, in our bill, on a yearly basis, the HMO carrier would be required to file and make publicly available annual mortality and morbidity rates for enrollees concerning procedures that were performed or diagnoses treated by the providers. It would require disclosure of average cost and length of stay for enrollees in a healthcare facility. It would require disclosure of the total number of each type of provider employed or contracted with the insurer. It would require disclosure of the evidence of level of enrollee satisfaction, and it would require the results of all regulatory and accreditation surveys. Consumer choice issues can and also should be addressed by disclosure of performance data, information of how gatekeepers control access to specialists, information on financial incentives for the provider, information about grievance procedures, information about who owns the insurer. In a commentary in Consumer Protection and Managed Care, Find the Balance in Health Affairs, Volume 16, Walter Zellman opines that disclosure is a highly effective, less onerous, and much less expensive than a proliferation of statutes and regulations mandating specific rules and activities. He goes on to find that that mandate would not represent an unreasonable burden on plans. Although our bill does have some specific rules and activities that are mandated, a main focus is on disclosure. As HMOs exist today, there is a great disparity between the producers of the service and the consumers of the service. One of the specific activities our bill does require in addressing that concern is that the governing board of the insurer must establish a means to allow the enrollees, the consumers, to have a meaningful opportunity to participate in matters of insurer and health plan policy and operation, such as being members of advisory boards. As and if we continue down the managed care path, and I'm not sure we will in the future, but if we do, we must, of course, find a balance between legitimate concerns about quality, access, and choice, and the need to allow the HMOs to evolve and experiment in generating ongoing savings and quality, and in improving quality. But in no event should we forget the importance of the consumer. There have been many bills dropped in the Oregon State Legislature this session on the issue of managed care. A task force of different interest groups have been meeting over a period of weeks. The ONA has been there at those meetings. They've been meeting to try and reach a consensus on those items that they can include in one overall bill. Public hearings begin on, that will be Senate Bill 21, correct? Yes, 21. Public hearings will begin on that bill next week. Interestingly enough, the bill is not finished yet. They're still talking about what can and cannot go into it. And in fact, as I understand, those discussions will continue this weekend. So it is very much an unfinished product. Some of the items that, at least at this point, there seems to be a consensus on of including is a requirement for a grievance procedure where a consumer is denied certain procedure or certain care or certain access to the system in a way that they can then go in and grieve that denial. There also seemed to be a consensus on disclosure of certain information, not as much as what we want and would require under our Patient Protection Act, but at least a beginning. There seems to be a consensus of a general disclosure regarding risk-sharing arrangements a plan has with its provider, the financial arrangements. And it also allows for clinical sovereignty. That means allowing the physician, the provider, along with the consumer, to make decisions about health care. However, that provision really doesn't have any teeth, because what there has not been a consensus about is if you do that, if you exercise that sovereignty, you can't be penalized. So, you know, you only have half of a loaf here. I want to leave you time for questions, but I want to finish this by just briefly telling you what other states are doing. 18 states have enacted legislation banning use of the gag clauses. 29 states have mandated hospital stays for mother and newborns. There are at least 8 states that have enacted more comprehensive patient protection acts. One thing, I said I was having hearings yesterday till 8 o'clock in the evening. Those hearings had to do with Measure 16, the Assisted Suicide Initiative. We have had over 4 days of 3 to 4 hours a day. Some of the testimony, or much of the testimony that was given in relationship to that bill impacts directly on what we think about managed care. And I would just like to take a second to read from two of those testimonies. The public must be assured that their most vulnerable have full procedural safeguards. One of the most troubling aspects of current developments in healthcare is the arena of medical decision-making unduly being influenced by financial concerns. This testimony ranges from the managed care containment of cost to the inability of suffering individuals to have appropriate facilities available to them during their terminal illness. And from a physician, she states, "In the era of managed care, I see and hear of patients who do not get care that they would have had in years past because that care puts their doctor at risk financially. Assisted suicide would create an unacceptable conflict of interest for physicians. Clearly, it would be cheaper to subtly guide a patient to choose assisted suicide rather than the more expensive hospice care. This is really not about the pros and cons of assisted suicide. It is how our delivery of health care is affecting these very basic issues that we are facing today." Thank you.
Steve Moskowitz, the first question.
My question is for Professor Rothschild. You talked about the de-skilling of nurses, and I wonder to what extent there might be some kind of countervailing force at work, that is, the extent to which nurses are replacing or might be replacing doctors in providing primary care, and how that might allow for the enhancement of the nursing profession.
We actually asked registered nurses in our survey to what degree or to what extent are you seeing the substitution of advanced practice nurses. That would include family nurse practitioners, pediatric nurse practitioners, for physicians, and only 14% reported a substitution effect in that direction. So it was, it's certainly occurring, but not to the degree that one might anticipate. There are, though, going to be changes, not only in the numbers and mix of nursing personnel, but certainly physicians. And there are changes underfoot in the graduate medical education monies that will, I think, significantly cut back the number of physicians and residency training slots in this country and provide perhaps more opportunities for nurses. The American Nursing Association is struggling right now to try to come up with a labor forecast to see where there will be new opportunities for nurses and what the needs are of the American public so that we can be best positioned to meet those needs. So we are working vigorously to try to be proactive, although I hate that word, but a step ahead of what's happening in healthcare so that we're in the right place at the right time.
Hello, I'm Jeannie Dodson-Edgars, member of the City Club, and I'd like to address quality. In the decision-making that a physician has in deciding on patient care and where that patient or consumer is, that physician often relies in the acute care setting on the registered nurse, or whomever it happens to be. I want to ask the public, whom would they rather have be recommending? A high school graduate, or someone with 2 years of chemistry, a year of physiology, a year of biology, a year of calculus, 3 years of training, in addition to that, a bachelor's degree, and a year of internship? I think the public's answer would be right, that they would rather have an educated nurse than a trained nurse. My question is, when will the registered nurse be recognized as a critical member of that healthcare team to help the physician make those decisions?
I'd like to make one comment about that. In the legislature, in the last session, when we were discussing these issues, people tried to see them as labor issues, and they are really not labor issues at all. What they are, and it's so important to remember, especially under managed care, the acuity of the patients that are, the illness level, I should say, of the patients who are now in our hospitals is much more than it was prior to managed care, and yet we are asking the less skilled to take care of those people. Well, that just doesn't even make common sense when you think about it. And so we are all going to be consumers, whoever we are, at one time or another, of health care. And it's certainly to our benefit, even if you want to be selfish about it on an individual level, to make sure we have the most skilled person there taking care of us.
It's not occurring, though, so when will it start? I graduated from UCLA School of Nursing in 1972.
We have a number of other questions.
I realize that, but I want people to understand background.
Yeah.
I'm Dr. Ewan Horniman, retired, and I'm one of those geriatric wrecks who are just pushing up the price of medicine in this country. Now, I think that it's wonderful that I can go and join the Good Health Plan or Legacy, and I don't pay any of the charges which Medicare charges. They give me everything free. I go see the doctor free. I don't pay to go to hospital. It's absolutely wonderful. I haven't accepted the offer of the Good Health Plan, except because I got a sneaking suspicion that I would get the sort of care that I'm paying for. And doctors work for money, you know, we're human. I was human once, and I've always worked for my money the old-fashioned way. As somebody once said, I worked for it and was paid for it. But the way doctors work depends on how they're paid. Now, if there's no profit, if they are working fee-for-service, they want to provide service because they get paid for it. If it's capitation, they've only got their ethics to push them. If they're risk-sharing, they're discouraged from providing services and referring and having investigations done because it costs them money. Well, the thing that really bothers me, I think it's absolutely right. Everybody should have the chance to join the Good Health Plan and pay nothing. But I really feel there's a concern. I have a real concern.
Can you come to the
that
question, please?
Yes, I will in a moment. Looking at the publications of the HMOs, nowhere can I find out how doctors are being paid. Now, my question to you is, how do we in this organization make it mandatory that HMOs publicize the way they pay their doctors in their brochures? Because this is a critical issue.
That is part of our patient protection bill, that information is made public. I don't know if our bill will pass. One thing you learn in the legislature is you start out in one session and hope in the next couple sessions you actually end up where you want to go.
Hi, good afternoon. It's a pleasure to be here. I'm Mary Foley. I'm Vice President of the American Nurses Association and a nurse in California, and I'm a guest of the Oregon and Washington State nurses. For your information, to let you know that this is an issue of national magnitude. As of yesterday, we have a new bill that has been introduced in the U.S. Congress, not at all unlike yours, and my congratulations to you, Representative, for your wonderful work. H.R. 1165 has been introduced on behalf of the American Nurses Association, and it is our Patient Safety Act, which has been reintroduced this year. It specifically addresses those issues that you're focusing on regarding disclosure, information to the public, so that they can make informed decisions, and Judith's points about nurse-sensitive information, so that we aren't waiting for the morbidity and mortality reports. It also goes to the whistleblowing, the healthcare worker protections that are necessary so the truth can be told. But I wanted to ask Judith a question particularly about any distinctive findings that you had in your study, which was wonderful work, that is different in the Northwest or similar in the Northwest that maybe the area folks here would like to hear about.
We did find several differences in regards to patient outcome measures. Family complaints and patient complaints on average across the country were about 50%. In Washington State, they were up around 58%, and in Oregon, interestingly enough, down 35.9%. You also, in this state, have nurses reporting much higher rates of decreases in length of stay. In the national survey, it was about 66%, and here it's almost 75%. Would you, the question about 2 out of 5 nurses nationally said they would not recommend a family member receive care in their facility. That dropped in Oregon to 22%. And consistent with that finding, we asked the nurses nationally their perceptions of whether the care was very poor, average, good, or excellent. Nationwide, the nurses were just about split between those who said the care was good or excellent and those who said it was average or poor. But here in Oregon, you had almost 59%, which is an overwhelming number of the nurses saying the care is good or excellent. And I think that's important to highlight some of the positives, because although everybody says we should have a healthcare system that resembles California, I think the take-home message is we would all be a lot better off if we had a healthcare system that resembled Oregon's, even though there are problems with it.
Don Williams, City Club member. Dr. Rothschild, your study focuses on an evaluation of the system by nurses and who it could be asserted have a vested interest in having a high professional-patient ratio. And I was just wondering, are there any other scientific studies that you're aware of where there's objective data that indicate that we're really worse off under managed care? For example, lives shortened, diseases not diagnosed, or just the quality of life adversely affected?
Right. In the publication, it appears in the November issue of the American Journal of Nursing. The research team went through, and for every significant finding that we reported, we actually went into the medical literature, not the nursing literature, but the medical literature, to substantiate the perceptions of the nurses. And I can tick off many findings. Subacute care facilities, for instance, received the lowest marks by nurses for quality of care. And when you go into the medical literature, there's an excellent review article in The Lancet, which is the British medical journal, about the inferior care and subacute care settings in the United States. And so for every finding, we did go in and back it up with other empirical data. And I feel that there was not one instance where the nurses' identification of trends or perceptions was not supported by secondary data sources.
Joe Eusterman, City Club member. Before I ask my question, I want to tell my fellow members of the City Club that I was one of those 30 or 40 people who testified before Representative Uherbelau yesterday in the Judiciary Committee and kept her and Chairman Sunseri there till 8 o'clock last night. And I really want to thank her publicly for the care that she showed in hearing all of us out yesterday. It was magnificent. Thank you. My question has to do, and I'd like to direct this to both speakers, if I may. And I should preempt that also by saying that, or preface it by saying that I can't help, but I can't commend you highly enough as nurses for bringing up so forcefully this body of information. Many of my physician colleagues have been trying to do the same thing, but I don't think they've been quite as successful as you have, and I want to commend you for that. My question relates to the corporate practice of medicine. It's my understanding, and I have in my hand here an article from the American Medical News, and it talks about the corporate practice of medicine being illegal in this country, dating back to the 1920s. And it says, case Richard B. Berlin, MD versus Sarah Bush Lincoln Health Center. This is in Illinois. Issue: can doctors be employed by hospitals or other entities not licensed to practice medicine? Illinois State Appeals Court ruling: no. A 1923 corporate practice of medicine law clearly bans this. Have you considered these laws that many states have against the corporate practice of medicine in your studies and in your legislation?
I'd like to respond to that quickly. I was asked by a reporter from a national newspaper yesterday, why is it that the nurses' voices are being heard so loudly as advocates for patients, and what is my explanation for why the medical profession has been so quiet? And my response was that maybe organized medicine is quiet, but physicians at the bedside are not. I received in my office a call to action from a group of physicians headed by a Nobel laureate. It's signed by some of the most prestigious physicians in the Commonwealth of Massachusetts, Mitch Rabkin, who's a physician that heads Beth Israel Hospital. Somewhat of a dinosaur these days, having a physician still in the CEO position, but gratefully he's there. And Steffi Wilhandler and David Himmelstein and I could name a number of other people who are renowned physicians and well recognized for their scholarship and medical knowledge. They are calling for an end to corporate medicine. And their intention is to get as many signatures as possible from the medical community on their call to action, to publicize it in the New England Journal of Medicine, which is by any measure the most prestigious medical journal in the United States, and to rally the medical community behind what I think we in nursing have been the leaders for quite some time, which is to say profiteering in healthcare has got to stop.
Dan Goldie, City Club member. We have abundant evidence over the years that if you provide private sector of our economy with sufficient financial incentive, it releases tremendous ingenuity in obtaining their goals, which is increasing the bottom line. Now, when you attempt by regulation, law regulation, to curb excesses, you can do some of it, but you're always lagging behind because the incentive for ingenuity exceeds the ability of lawmakers to catch up and regulate. So my question is this: has anybody given thought to the possibility that if we're seeing a takeover of fee-for-service type of medical care by managed care or managed cost care, can there be any financial incentives devised so that the financial incentives are on the side of providing better medical care rather than worse medical care in order to increase the bottom line?
Yeah, I'd like to respond to that. Actually, the idea of managed care itself, I think, has very many positive things to recommend. We have gotten off track to the managed costs idea, I think. But managed care is an incentive. It's an incentive for all of us, not only the providers but the consumer, that if you practice preventative medicine, healthcare then becomes less costly, and I think it benefits all of us. Unfortunately, under the fee-for-service system, we didn't practice preventative care, we practiced curative care, and that, of course, drove the cost of health care up. But it's, I'm not sure the official name, it's the Group Health of Puget Sound. They had this idea of a managed care type of organization years ago and have been very successful at it. I have a friend who was involved in the founding body of that, and they told me that because of managed care, the new managed care, that they are having all kind of problems now with their original idea. But I think there are concepts out there that are incentives and could work, but we're just off track at this point.
I'm Ted Falk, a City Club member and also the general counsel of what the speakers were referring to as a plan. I'm not sure how well planned the plans are, but that's another subject. Representative Uherbelau described the legislation that she's working on, and one of the focuses she spoke about was disclosure. And I think that probably disclosure is something that a lot of people, the plans, providers, consumers, purchasers, all can agree is desirable. Whether or not the legislation passes, I'm sure that the disclosure will increase in the future. But I'm just wondering, given, as Representative Uherbelau pointed out, that tends to unleash market forces, and I wonder what Professor Rothschild thinks will happen to the phenomenon of de-skilling and to the level of professionalism as market forces are really unleashed. Might not market forces prompt further de-skilling, as, for example, hospitals find that there is no basis for maintaining specified levels of nurse-patient ratios because they can't support it using their outcome data?
I have complete confidence that the outcome data will support that the more registered nurses you have at the bedside, the better the patient outcomes. There's absolutely no doubt in my mind about that. In fact, we generated that literature back 10 years ago, which is why we switched the mix from a minority of registered nurses at the bedside to a majority of registered nurses. There was pioneering nursing research that was done by Joyce Clifford at Beth Israel Hospital and Luther Christman at Rush University that demonstrated unequivocally that patients had better outcomes, that hospitals saved money when you used a higher mix and more skilled nurses at the bedside than the reverse. We are returning to failed models of providing nursing care in hospitals because, quite frankly, people who are running the healthcare system are interested in a quick fix. And many of the consultants that I have sat with on panels don't even know the history of how nurses' work has been organized in hospitals. They are looking at transplanted business plans, comparing cashing a check in a bank to getting lab results. And as I said at one of these exchanges in Washington, D.C., the day that you equate cashing a check at a bank to telling an AIDS patient or a potential AIDS patient what their lab result is the day you've squeezed the last ounce of humanity out of the American healthcare system. They are not equivalent, and God help us if they ever do become that way. There are ways we can deliver care cost effectively. And I think if we provide patients with the information about outcomes, it will become eminently clear that if you take our nurses away from the bedside, you not only adversely affect patients, but you drive up costs. It's that simple.
My name is Ruth Curry. I'm a club member. I have a comment, and then I have a question for both speakers, as well as the question would alert the members and people attending here. I'm a retired medical social worker, and I'd just like to say that medical social workers are also de-skilled because many in the hospitals are utilizing not trained medical social workers who can be very helpful in working with patients in their discharge plans. Many times I've experienced as a home health social worker a patient being discharged with no concept of who's going to care for them at home or their emotional state when they go home. Well, anyway, my question it has to do with the fact that you both spoke about along with the de-skilling. I attended a meeting this week where there was a representative speaking to the Gray Panther meeting from Association of Hospitals.
Would you come to the question, please?
Yes, in regard to bills that are in the legislature that would give a label to each of the different levels, but the labels didn't make any sense. Have you come across this at all? I mean, a consumer would not know who this person was. I mean, being a technician, a certified technician, doesn't tell anybody anything, does it?
The only
Have
thing
you heard of it?
Oh, maybe there was some confusion in what they were trying to report. For example, in our bill, we require that people wear identification on them. And I mean, this was very common. When I worked as a nurse, you always had your name and RN after whatever you are. Now in many hospitals, you go in and you have no idea who is taking care of you. So the only purpose was to identify the caregiver.
Well, this is a particular bill asking, and they be listed. It wouldn't be a nurse, it'd be a certified, registered, without saying nurse or whatever category it was.
I don't know of any particular bill like that. I only know of what's in ours, that people have to identify who they are to care.
Well, something seems to be afloat in that area.
Mm-hmm.
It's time for one more question.
My name is Dick Brownstein. I'm a member of the City Club. I'd like to have you address further the issue of disclosure. Maybe both of you do that. My concern is that we're becoming something of an over-disclosure society, and that notwithstanding disclosure, things continue kind of as they were, and that, as I understand, for example, the Securities and Exchange Commission is going to try to cut back on the amount of disclosure required because people just don't regard it. They don't look at it. And when I heard the representatives listing of all the things to be disclosed, I'm just concerned that it's going to just be one of those pieces of literature that hit the wastebasket. And I would like you to address that. The other part of the question is I believe in this state, and maybe, well, let's just talk about this state, that aside from the Kaiser Permanente organization, all the healthcare providers are involved in a whole range of service opportunities, from fee-for-service to preferred provider organizations to HMO panels. They all do it all. And what I'm wondering then is why or how disclosure by a particular plan or group is going to be effective as distinguished from disclosure by the provider of what his or her or its record has been?
Well, I guess I'll respond first, is the consumer has some responsibility here. It's just like when you go out to buy a car, there's a lot of information out there. Some consumers don't bother with reading the information and will go buy their car blind. Well, in this case, as the same thing will happen to the consumer of health care, if they are really interested in getting the best health care at the most economical price, then they are going to take the opportunity and the time to look at that information. And RBL requires that information to be made public. But you can't, you know, as they say, you can only lead the horse to the water. You can't make them drink. There has to be some responsibility put on the consumer. But it should be available. Right now, it is not available in the main.
There was an article on the cover of the Wall Street Journal that I think highlighted some of the points that the gentleman just made, that healthcare plans are collecting the information, but the business community, the purchasers of health insurance, aren't interested. They were only interested in the bottom line, what the premiums would be. And that's why, frankly, I'm here today to try to pique your interest, and why I really am grateful for this opportunity to speak to all of you. Because it is up to all of you in this room who are the purchasers of health care insurance. When we say consumers, we think of each one of us as an individual, but it's the business community who buys insurance and makes that available as an employee benefit, who can make a difference in this battle. Thank you.
Dr. Rothschild, thank you for coming out from Boston. Representative Uherbelau, thank you for coming up from Ashland. We're adjourned.